Anemia of chronic disease. It will also have low iron, but ferritin is the acute phase reactant in inflammation. Because of that, in spite of low iron, ferritin being an inflammatory mediator will increase because of the anemia of chronic disease. And in them, how will be TIBC? It will be typically normal or low, right? Because it is not the absolute deficiency of iron, it is incorporation of the iron which is basically deficient in anemia of chronic disease. Then thalassemia, in them ferritin, iron, TIBC, all of them will be more or less normal, none of them are either low or high. That's how you identify thalassemia, which is the other form of microcytic hypochromic anemia. Out of all these parameters, doctor, ferritin is most reliable to diagnose iron deficiency anemia. It is a very sensitive marker. थोड़ा iron deficiency शुरू होते ही ferritin कम हो जाएगा very early. Then TIBC will elevate. There can be TIBC not yet elevated, but still ferritin will be low. You got my point? So it is more sensitive marker. Low ferritin is more sensitive marker than a high TIBC in case of the iron deficiency. Then there will be decreased serum iron. It is most insensitive. Last thing to fall down. First is low ferritin, then high TIBC, then low serum iron. Then microcytic hypochromic RBC is on the peripheral smear. Still, if you have doubt whether iron deficiency is there or not, bone marrow can help. In the bone marrow, you use a stain called Pearl stain, with which you stain iron. If it is not showing any iron, Pearl staining will show iron depletion. But we rarely do bone marrow biopsy to diagnose a simple iron deficiency anemia. Now, very commonly the source is from GIT, hence try to identify whether any occult blood is there in the stool. So guaiac positive stool test is another important test that need to be done. Then how about MCH, MCHC in the diagnosis of the microcytic anemia? Not very valuable, but MCV is very valuable because it will differentiate anemias into micro, macro and normocytic. Now how do you treat iron deficiency? We give oral iron supplement, ferrous sulfate is what we basically give, and always in the case of the men when there is iron deficiency anemia, men have no reason to lose iron. If they are losing iron means possibly they are losing to GIT, possibly due to a GI blood loss. That need to be evaluated, endoscopy, colonoscopy, all possible ways of identifying any GI source of blood loss. Postmenopausal women, premenopausal okay, can be explained by the menstrual blood loss. They need to be evaluated. And if you use iron sulfate, ferrous sulfate, constipation, nausea, dyspepsia, they won't be seen in all the people, but they are the intolerable side effects which can develop. Then you can also give iron dextran injection will be available, can be given IV or IM. Suppose if somebody had a poor GIT absorption of the iron, for them iron dextran is indicated. Generally you don't need transfusion, but if the patient is having any cardiopulmonary decompensated state, then they definitely require the blood transfusion is what need to be understood. Now in this context, we need to know one important term called RDW, red cell distribution width. What is the meaning of it? The word width, red cell distribution width is very confusing. A lot of people think maybe it is the diameter of RBC. Width बोल रहे हैं ना, diameter of RBC, मगर वो diameter of RBC नहीं है, क्या है वो? You will be plotting how many number of cells are of the 60 is the MCV, how many cells have 70 mean corpuscular volume, how many have 90 mean corpuscular volume. Like that you will be plotting. On the x-axis will be the different sizes possible, y-axis will contain number of cells having that particular size. Then you typically get the distribution. छोटा cells कितना है, लंबा cells कितना है, बड़ा cells कितना है, मोटा cells कितना है, पतला cells कितना है. Then when you plot it, suppose if the patient is having poikilocytosis, that is his bone marrow is excessively producing RBCs, then all cells will not be of uniform size. Typically they will be of small cells, big cells, medium cells, all kinds of cells will be there. Poikilocytosis means. That is reflected by increased red cell distribution width. You are able to get me? Matlab, on the extreme right hand side of x-axis, what do you have? Cells of very big volume. On this side you have cells of small volume. All the types of cells are there. Hence red cell distribution width has become bigger. But if the entire red cell distribution width is narrow, then you call low RDW. How to interpret RDW? RDW is a reflection of poikilocytosis. Poikilocytosis is typically a feature of iron deficiency anemia. When iron deficiency is there, there is poikilocytosis. Neither in thalassemia nor in sideroblastic anemia nor in anemia of chronic disease you find poikilocytosis. And how do you identify there is poikilocytosis? By calculating the RDW. Hence RDW become typically increased in the case of only iron deficiency anemia, not in other forms of microcytic anemia, is what I want to once more underscore to all of you. So you have typically the patients who are having microcytosis and at the same time increased RDW, which reflects that they have got poikilocytosis, which is typically seen in the case of the iron deficiency anemia, is what need to be remembered. Now comes a very important area, doctor, which is called as transfusion medicine. What are the various blood products that you can give? You are sitting in that super store of blood products. You have Nirma Surf, Vim Surf, Surf Surf, so many types of products are available. किस किस situations में किनको आप कौन सा blood product देगा, that is very important. Now doctor, packed RBCs is a very common transfusion product that we use. When do you call packed RBCs? How it is different from the whole blood transfusion? Packed RBCs में platelets नहीं है, clotting factors नहीं है, खाली RBCs है. How do you get them? You take the whole blood and centrifuge and take out only the RBCs and pack them and then deliver it to the superstore. How can you deliver them? You need to deliver them with something, no? Generally we use normal saline to infuse them faster. You also have an option of using ringer lactate in order to infuse them, those packed RBCs. But if you use ringer lactate, in the ringer lactate you have calcium, which will lead to thrombus formation of those packed RBCs. You may ask a question. You can also use 5% dextrose. What are the different fluids available for you commonly? Ringer lactate, DNS or 5% dextrose. DNS means normal saline plus dextrose, right? You have 5% dextrose, 10% dextrose, 25% dextrose, different forms of only dextrose and water. Okay? Why you call D5W? It's the 5% dextrose with water. 25% D25W means 25% dextrose with water. You can give in that. Third is purely normal saline. Between these three fluids, we prefer normal saline. Why? If you give it with ringer lactate, packed RBCs typically undergo clot formation. If you give them along with dextrose, that lead to hemolysis because the water becomes sucked by the RBCs and they swell and break. Hence we prefer normal saline to infuse the packed RBCs. ठीक है भाई, 1 unit packed RBC is delivered. Next day when you check how much should hematocrit should increase. Hematocrit should increase by 3 to 4 points. Hemoglobin should increase by 1 gram. Matlab, suppose your patient is having 8 doctor hemoglobin. You have given 2 units of packed RBCs. Next day when you check, his hemoglobin should be 10. If hemoglobin rises by 2, hematocrit rises by 6. If hemoglobin rises by 1, hematocrit should rise by 3. Rule of 3, which you are not going to forget. And always check the CBP. Post transfusion is a very important thing. What is the reason you want to check CBP? You want to know whether hemoglobin improved or not? Or suppose if you have done a mismatched transfusion, what will happen? Hemolysis will occur and hemoglobin further gir jayega. So that is the reason you need to do. Then second type of transfusion product is fresh frozen plasma. इसका मतलब क्या है? होल ब्लड को लेके उसमें से आरबीसी निकालो, डब्ल्यूबीसी निकालो, प्लेटलेट निकालो, जो रह गया उसको बोलते हैं fresh frozen plasma. Fresh frozen plasma contains rich, abundant amount of clotting factors. Where do you want to give fresh frozen plasma? Suppose somebody is having sepsis, consumptive coagulopathy. Due to the sepsis, he has got a disseminated intravascular coagulation, consumptive coagulopathy, all his clotting factors got broken down. And now he is profusely bleeding. For him you want to resuscitate. You want to give all the clotting factors which are consumed by in his body. For him you will give fresh frozen plasma. Somebody is receiving warfarin. There is a overdosage of the warfarin. Warfarin, how does it basically act? Warfarin is anti-vitamin K. Vitamin K dependent factors are 2, 7, 9, 10. Excess warfarin will cause 2, 7, 9, 10 totally gone. You want to replenish him. You need to give fresh frozen plasma is what need to be remembered.